Welcome to section 4 of cardiac pathology. In this section, we'll be discussing aortic dissection and aneurysm. Let's get started. Aortic dissection is when a tear in the tunica intima extends into the tunica media, which can then dissect proximally or distally through the aorta. This occurs because of a pre-existing weakness in the tunica media. This weakness allows intimal tears to extend into the tunica media, resulting in dissection. So from normal histology, we have the tunica intima, which we can see right here, followed by the tunica media, and finally the adventitia. If a tear occurs in the tunica intima like this, it can extend into the weakened tunica media and then travel down the wall of the aorta. There are two types of aortic dissection, including proximal and distal. Proximal is also known as Stanford type A. This involves the ascending aorta and may extend to involve the heart. If this occurs, it can result in cardiac complications such as cardiac tamponade or aortic regurgitation. It may also involve the descending aorta, but this is in addition to the ascending aorta. Distal dissection is also known as Stanford type B. This involves only the descending aorta. Here's an image that depicts the two types. Notice that with Stanford type A, both the proximal and distal aorta can be involved, whereas with Stanford type B, only the distal aorta is involved. So with Stanford type A, the proximal aorta is involved right here, and then we have the proximal and the distal involved as well. Whereas with Stanford type B, only the distal part is involved, as we can see right here. Notice that in every case, there is a tear in the tunica intima. Risk factors for aortic dissection include hypertension, age, and genetic defects. As you'll see in a second, all of these lead to one common outcome: weakening of the tunica media. For step 1, it's high yield to know that hypertension is the most common cause of dissection. You'll often see this as an answer choice along with smoking, diabetes, obesity, and others to confuse you with atherosclerosis. So with hypertension, hyaline arteriosclerosis of the vasa vasorum prevents adequate perfusion to the tunica media. This leads to smooth muscle atrophy, which then causes weakening of the tunica media. With age, patients experience disruption of collagen, smooth muscle, and elastin in the tunica media. This is replaced with a mucoid extracellular matrix, and this again leads to weakening of the tunica media. With genetic defects, there is disruption of the extracellular matrix, such as patients with Marfan syndrome who have a fibrillin 1 defect. This leads to fragmentation of elastic tissue in the tunica media, which then results in weakening of the tunica media. So to review, the three major risk factors for aortic dissection are hypertension, age, and genetic defects. Each of these have somewhat unique pathophysiology, but they all lead to weakening of the tunica media. So remember, aortic dissection is due to weakening of the tunica media. When an aortic dissection occurs, it typically presents with sharp, sudden onset chest pain that radiates to the back. A widened mediastinum may also be seen on chest x-ray, as well as a double lumen on CT. Here is a CT of the chest. We can see the arrow pointing to the aortic dissection. Notice a little gray space between the lumen right here, which creates an appearance of a double lumen. The gray space is the tunica intima that has been torn from the wall of the aorta. Histological examination will reveal cystic medial degeneration and fragmentation of elastic tissue. So basically, the tunica media has degenerated and has been replaced with a cystic-like appearance, and the elastic tissue normally present in the tunica media appears fragmented. Here's a histological image of the aorta. On the left is low magnification, and on the right is high magnification. At the higher magnification, it's easier to note the cystic-like spaces, which we can see right here. This makes the tunica media appear abnormal. It's very important that you know how to distinguish this from atherosclerosis. Recall that atherosclerosis affects the tunica intima, and this results in the formation of an atheroma. And while a tear in the tunica intima does occur in aortic dissection, it is primarily a result of weakness of the tunica media that predisposes these patients to the dissection. Another condition that's similar to aortic dissection is traumatic aortic rupture. However, this is when a tear occurs through the entire wall of the aorta from the tunica intima to the adventitia. This most commonly occurs following a motor vehicle accident. The tear is usually at the isthmus of the aorta, just distal to the left subclavian artery. And finally, mediastinal widening may be seen with imaging. Here's an image that shows the anatomy nicely. We can see the left subclavian artery right here, and the isthmus is a small segment of the aorta just distal to it right here. Again, rupture typically occurs at the isthmus. All right, let's move on to discuss aortic aneurysm. This is defined as stress-related dilation of the aortic wall. Keep in mind that a true aneurysm involves all three histological layers, from the tunica intima to the adventitia. So with this in mind, you should be able to deduce that an aortic dissection is a false aneurysm. It results in dilation of the wall, but not all three histological layers are involved. There are two types of aortic aneurysms, including abdominal aortic aneurysm, or AAA, and a thoracic aortic aneurysm, or TAA. Let's discuss AAA first. Unlike aortic dissection, AAA is highly associated with atherosclerosis. This, along with other risk factors such as age over 60, male sex, smoking, and hypertension, lead to chronic transmural inflammation of the aortic wall. I'll say it again because it's high yield. AAA is due to chronic transmural inflammation of the aortic wall. Inflammation leads to the release of enzymes, such as metalloproteinases, which degrade elastin, weaken the wall, and ultimately cause aneurysm development. Additionally, atherosclerosis results in buildup on the tunica intima, which decreases the perfusion to the tunica media. This causes atrophy and weakness in the aortic wall. AAA is most often asymptomatic. However, when there are symptoms, it typically presents with abdominal, back, or flank pain. The classic triad of rupture includes acute pain, hypotension, and a pulsatile abdominal mass. Finally, the risk of rupture increases significantly when the diameter of the aneurysm is greater than 5.5 centimeters. All right, now let's discuss thoracic aortic aneurysm. Unlike abdominal aortic aneurysms, thoracic aortic aneurysms are non-atherosclerotic in nature. Most are idiopathic or sporadic. It's associated with connective tissue-related genetic defects, such as Marfan syndrome and Ehlers-Danlos syndrome. This is because these genetic disorders cause degeneration of the tunica media, which then weakens the aortic wall and results in aneurysm development. Less frequently, thoracic aortic aneurysms are associated with infections, such as tertiary syphilis, or they may be associated with inflammatory disorders, such as Takayasu arteriitis. In these conditions, there is inflammation of the vasa vasorum, which leads to ischemia, atrophy of the aortic wall, and aneurysm development. Thoracic aortic aneurysms often present with aortic regurgitation, and this is because the aneurysm will be in close proximity to the aortic root, which can then result in aortic valve insufficiency. It can also compress adjacent structures as it expands, resulting in hoarseness, dysphagia, and pain. If it ruptures or dissects, it will present with hemodynamic collapse and severe sudden onset chest pain or back pain. Mediastinal widening can also be seen with imaging. When viewed under the microscope, these appear very similar to aortic dissection. In both conditions, there is degeneration of the tunica media with a cystic-like appearance. Again, here is a histological image of the aorta, and we can see degeneration of the tunica media with a cystic-like appearance that has replaced this region. All right, now that we've covered the information, let's review with a question. A 67-year-old male presents to the emergency department due to sudden onset chest pain that began approximately 30 minutes ago. He states that the pain is 10 out of 10 and radiates to his back. A chest x-ray reveals a widened mediastinum. An EKG is normal. A D-dimer is normal. Which of the following is most likely associated with this patient's condition? A. Ventricular pseudoaneurysm. B. Aortic regurgitation. C. Pericarditis. Or D. A swollen calf. Okay, hopefully you notice that this patient has a classic aortic dissection presentation, including sudden onset chest pain that radiates to the back and a widened mediastinum. With this in mind, the correct answer is B. Aortic regurgitation. Recall from this image that Stanford type A dissections can dissect in a way that involves the heart, so they can dissect downward like this towards the heart, and this can cause cardiac tamponade or aortic regurgitation. A and C are wrong, as these are both complications of myocardial infarction. This patient's EKG is normal, and there was no mention of troponin enzymes or other features that would lead us to believe that this patient is having a heart attack, so A and C are wrong. D is a reference to a pulmonary embolism. However, this is unlikely considering that the D-dimer was normal, so D is incorrect. And again, the correct answer is B, aortic regurgitation. And that concludes this section.